Now we will hear about axial PsA management from Professor Laura Coates, and she's from the University of Oxford in the United Kingdom. Laura, tell us please about the management of axial PsA.
Hello, my name's Laura Coates, and I'm a researcher from the University of Oxford, and I'm speaking today about resetting our expectations in the management of axial psoriatic arthritis. These are my disclosures. Now, when we think about psoriatic arthritis, we're aware that this is a very heterogeneous disease, but it's easy to assess disease if we split disease out into the 6 key domains that we see in psoriatic arthritis. I think as rheumatologists, we're always very aware of the peripheral arthritis. We're thinking much more about the management of skin and nail disease, as that's a key issue for many of our patients with psoriatic arthritis. But we're also increasingly thinking about the involvement in entheses, dactylitis, and the axial skeleton when we're planning treatment for people with psoriatic arthritis. Now, when we think about psoriatic arthritis, it's obviously part of the spectrum of spondyloarthritis, and that's clear when we think about classification criteria for the disease. So here you can see the classification criteria for psoriatic arthritis as informed by the Caspar group. And right at the top, you can see that the stem of the Caspar criteria requires inflammatory articular disease either in the joints, the entheses, or the axial skeleton. Alongside fulfilling the points below, this would mean that patients with axial involvement can fulfill the Caspar criteria and be classified as psoriatic arthritis. However, when we think about the ASAS classification criteria for axial spondyloarthritis, you can see again here that psoriasis is highlighted. So patients who have a feature like psoriasis can also have a diagnosis of axial spondyloarthritis under these criteria if they have imaging evidence of sacroiliitis or a positive HLA-B27. So this starts to demonstrate the overlap between the two conditions. And this is clear when we look at patients. If we take a cohort of patients with psoriatic arthritis and AS and fulfill these two different criteria, this is looking at the modified New York criteria, which requires radiological change, and the Caspar criteria, which I showed previously. And you can see here that around 25% of patients fulfill both criteria. Now, when we think about axial psoriatic arthritis, there's been a big issue in estimating the clinical epidemiology of this condition because there is no universally recognized definition. That can make it difficult to recognize when we're in clinic. We know that a small number of patients with psoriatic arthritis have solely axial disease. Usually they fulfill more than one of those 6 domains shown earlier. We know from follow-up studies, this time done in Canada, that around 15% of patients will develop axial disease, and the diagnosis of axial disease seems to go up with longevity of disease. So over a 10-year period, we see an increasing prevalence of axial involvement. And in long-standing psoriatic arthritis, depending how it's defined, we may see quite a high proportion with some suggestion of axial involvement. So who gets axial psoriatic arthritis? This slide shows some of the recognized risk factors, again taken from the cohort in Toronto. And this is looking at patients when they were first diagnosed and also when they were followed up quite a number of years later. You can see here that there's a higher risk in those with nail dystrophy, those with more damaged peripheral joints, so more severe disease overall, potentially unsurprisingly with an ESR and with a HLA-B27, given the association with axial symptoms. Now, when we think about back pain in psoriatic arthritis, obviously back pain is a very common issue, and it's not necessarily always going to be related to axial involvement. In a lot of our patients, they may have mechanical back pain. When this cohort was examined, they looked at 171 patients with psoriatic arthritis, and over half of them had back pain on direct questioning, but a fair proportion of these were non-specific back pain and were not necessarily felt to be inflammatory. There was a moderate to good agreement between the inflammatory back pain criteria, the published criteria in axial spondyloarthritis, and a rheumatologist opinion of whether this related to inflammatory axial disease. But when they looked at patients with back pain compared to those without back pain, they actually showed quite similar characteristics. Apart from minor differences in BASDI and in genetic markers, actually a lot of their clinical presentation was similar. So it can be very difficult to differentiate even using symptoms, investigations, and imaging. And then the other issue is really how we measure disease activity and therefore response in axial psoriatic arthritis. The most common way of measuring axial involvement is using patient-reported questionnaires, such as the BASDI, or sometimes combined into measures like the ASDAS. But these rely on patient questionnaires that can be high, even in patients who don't have inflammatory axial disease. What you can see here on the graph is that those patients with active peripheral disease who had no confirmed axial involvement at all actually showed a similar correlation with their overall patient global and BASDI as those with axial disease. So the patient-reported outcome measures that we use are good at displaying disease activity, but they're not good at differentiating whether this is due to symptoms in the peripheral joints or in the spine. Now, obviously, one of the mainstays of investigations for axial involvement is going to involve imaging. And whilst we see similar changes in AS, axial SpA, and psoriatic arthritis, there are some differences which have been noted in larger cohorts. Typically, the involvement in psoriatic arthritis is more likely to be asymmetrical, and that's crucial when we think about classification criteria such as the modified New York criteria. But also we see slightly different shaped syndesmophytes, which sometimes can be helpful in terms of a diagnosis, but often at an individual level, it's difficult to tell the difference. This data shows you again the radiographic differences that we see between AS and psoriatic arthritis. You can see here that much higher rate of symmetry in AS compared to psoriatic arthritis, much higher rates of complete ankylosis at the sacroiliac joints. So there may be more mild disease in the psoriatic arthritis patients compared to AS in the sacroiliac joints. And then also in terms of bridging syndesmophytes, these are less common in the psoriatic arthritis patients. Now there's a major issue in terms of consensus diagnosis and definitions in axial psoriatic arthritis. We know that classification criteria are not necessarily designed to be diagnostic criteria, but often they are used in clinic when making diagnoses, and there's inconsistencies in how these have been applied in previous studies, which makes it hard for us to really understand how psoriatic arthritis presents. When we think about the modified New York criteria, these are obviously useful in terms of finding a definite radiographic change, but given that they often rely on severe changes at the SIJ or symmetry, they may well be negative in quite a lot of patients despite them having active axial psoriatic arthritis. The clinical criteria, as we've seen before, have issues in terms of agreement with the rheumatologist opinion, and it may be difficult to differentiate from mechanical back pain or other causes of back pain. Some studies have looked at minimal radiographic evidence, for example, a unilateral change in the sacroiliac joints rather than a bilateral change, but that potentially reduces our specificity in these trials. And those stringent radiographic criteria will mean that we're definitely looking at psoriatic arthritis when this is found, but we may be missing a number of cases as well. Now, there's a large project currently underway, which we hope will help us in the future with exactly this problem. The ASAS group and the GRAPPA group have come together to look at the definition of axial psoriatic arthritis, as it clearly falls in the overlap between these two societies. The first project looked at a 1,000 Minds survey, comparing different clinical vignettes of patients and asking experts from both the ASAS and the GRAPPA group to vote on the items that they thought really helped to make a diagnosis. Perhaps unsurprisingly, it was found that imaging evidence of axial involvement was the strongest identifier that the rheumatologists would link to a diagnosis, but there are still many questions left to be answered. And so there are future projects planned between ASAS and GRAPPA looking in prospective studies to try and improve this definition. Now, when we think about treatment of psoriatic arthritis, the GRAPPA treatment recommendations split this out into the 6 domains that you saw right at the beginning of the talk, so that we're thinking about treating patients by domain, and then where they have more than one domain involved, we're ideally picking a treatment that will work for all of those different domains at the same time. This slide shows the axial psoriatic arthritis section in more detail. Now, these recommendations were first published in 2015, and at that time there was no clear evidence specifically in axial psoriatic arthritis, and so you can see the caveat here that this is based on evidence from broader axial spondyloarthritis trials rather than specifically in psoriatic spondylitis. It's shown that DMARDs are not effective for axial disease, which I think is now well recognized, that we have good data for TNF inhibitors and for IL-17 inhibitors in the form of secukinumab, but some other drugs have been found to be ineffective. At the time that we wrote these recommendations, there was a suggestion that ustekinumab may be helpful in a small open label study, but a subsequent RCT has been negative, and we've also seen negative RCTs with apremilast and with IL-23 inhibition. So it's important that we consider the different domains of disease, and if patients do have axial disease, that we pick a drug that's appropriate for that patient and will help to control the axial involvement. Now, obviously, one of the big issues we highlighted back in 2015 in these recommendations is that we don't have any direct evidence in axial psoriatic arthritis. The good thing is that since 2015, this has now changed. So this slide shows the design of a study called MAXIMISE, which looked at secukinumab versus placebo in people with axial psoriatic arthritis. So these patients were randomized into 3 equal groups, either placebo, secukinumab 150 milligram, or secukinumab 300 milligrams. So the 2 doses that are commonly used in psoriatic arthritis. And you can see here that those patients who did not respond to placebo were then re-randomized to the 2 different doses of secukinumab at a later stage. This study took patients who had a diagnosis of psoriatic arthritis according to the CASPAR criteria. They had to have active spinal disease as judged by their physician, and that's the gold standard that we use where there is doubt around the exact classification criteria. And they had to have active symptoms as indicated by a high BASDI score. They also had to have a high spinal pain VAS score, attempting to link that particularly to the spine, and an inadequate response to anti-inflammatories over the previous 4 weeks. The exclusion criteria really related to previous therapies in particular, and obviously safety around patients receiving such a drug. Now, when we look at the demographics of the group, you can see here that they're middle-aged, they're slightly older than we would expect from an axial spondyloarthritis cohort with an average age of over 40. They're still predominantly men, as we would expect again with any axial disease. They're slightly overweight, as we would expect really with the psoriatic arthritis cohorts, and they've had symptoms for quite a long duration in their spine and in their peripheral joints. And you can see at the bottom that around 30 to 35% of these patients were found to be HLA-B27 positive. Now that's obviously low compared to a cohort of AS patients, but probably about what we would expect for axial psoriatic arthritis. When we look at the disease characteristics of their psoriatic arthritis, the vast majority fulfilled different inflammatory back pain criteria, and a number of different criteria were checked within this study. They had high levels of disease activity judged by both the patient and the physician. They also had quite significant peripheral arthritis with high tender and swollen joint counts. So these patients have active disease in multiple domains as well as in their axial spine. When we look at the response rate, this is looking at the ASAS 40 over 52 weeks. You can see the primary endpoint at week 12, where you can see a clear separation between the drug and the placebo in favor of both the secukinumab 150 and the 300 milligram arms. And that met our primary endpoint and statistical significance for both doses. And then where those placebo patients switched over onto active therapy, they also showed a good response. You can see a rapid rise in the ASAS 40 after that time point. So we've got around 60% of patients achieving the ASAS 40 at the end of the 1-year study period. Now, obviously, given the caveats around outcome measures in axial psoriatic arthritis and that they may be affected by the peripheral joints, it was important to have an objective measure within this study, as well as looking at ASAS 40, which predominantly relies on patient-reported outcomes. So MRIs were performed in these studies, as you can see here at baseline, at week 12, and at week 52. And here you can see the results for the entire spine and specifically for the sacroiliac joints. And you can see a good separation between the two active drug groups and the placebo group. And then after week 16, when they switch onto active therapy, you can see again that they respond on the MRI just as they did clinically. So in summary, I think we recognize the multi-domain disease that is psoriatic arthritis more and more, and we're thinking about assessing patients fully so that we can address all of these different domains when we're treating people. It's clear that the axial involvement is often underdiagnosed and that we need to be aware of this and questioning patients about this to ensure that we identify whether there's disease activity in the spine, and if so, plan treatment appropriately. The MAXIMISE study is the first large RCT specifically in axial psoriatic arthritis, testing any drug to date, and it showed that both the 150 and the 300 milligram doses of secukinumab were superior to placebo treatment. This was both with clinical outcomes like ASAS 40, but also with the MRI changes in the spine and the sacroiliac joints. I think there's still a large ongoing research agenda in axial psoriatic arthritis. We need to understand better how to diagnose and classify the disease. If we can, we need to improve outcome measures so that we can monitor disease activity in clinic without just relying on MRIs. And we need to raise awareness of the axial involvement with our patients so that they report symptoms to us. Thank you very much.
Laura, we heard about the importance of axial PsA and the difficulty with classification criteria, but how do you diagnose axial PsA in clinical practice? Because back pain is such a prevalent symptom. How can you be sure that the back pain is part of axial PsA?
So I think the important thing to diagnose axial psoriatic arthritis is to have a high index of suspicion. I think we need to directly ask patients about back pain because they won't often disclose that without a direct question, particularly if they're seeing a non-rheumatologist, a GP or a dermatologist, where they feel it may be less relevant. And then we don't have clear diagnostic criteria or classification criteria, as you've heard in the presentation. So we're relying on physician expertise, but obviously informed by a number of factors. So I think the inflammatory back pain criteria are helpful. Obviously, our index of suspicion is going to be different potentially depending on gender, age, and the duration of psoriatic arthritis. And then obviously just as in axial spondyloarthritis, we're often using imaging to try and help to confirm a diagnosis, either with X-ray or MRI.
Laura, you told us about the MAXIMISE study. Is this study population representative of patients with axial PsA in clinical practice?
So I think when we think about study populations, we're aware that often there are differences between patients who take part in studies and those that we see in clinic. But I think they do represent a fair proportion of our patients who have axial psoriatic arthritis. I think the biggest difference between the study population and my patients is probably the level of peripheral joint disease. They had very high tender and swollen joint counts. Not all of our patients have such polyarticular disease, but I think the levels of B27, the levels of positive MRIs, and the kind of symptoms and impact that we saw reported probably are similar to those patients who have axial involvement in clinical practice. So I think this does help to inform my management of those patients.